Hello to everyone. My name is David Brennan. I am your host for this webinar. I'm really excited and pleased to be here and honored to be in such incredible company to have an opportunity to talk about inclusive digital sexual health services and research lessons from British Columbia, Canada, and the United Kingdom. I want to make sure that people are aware that we are recording the seminar, so please feel free to turn your camera off if you would prefer that your visual is not available. It's entirely up to you. We're happy to see faces in the crowd, but we're going to do what we're going to do whether we see your faces or not. So welcome. And I just wanted to let people know that as we have different speakers presenting today, you're welcome to select in the upper right-hand corner of your screen, or at least on my screen, the option to view just the speaker if you want to see a larger image of the speaker. Usually when people share slides, it opens up very, very widely. Again, my name is David Brennan. I'm a professor and I currently serve as the Associate Dean Research at the Factor-Inwentash Faculty of Social Work at the University of Toronto and a member of the Get Checked Online team and DISHI. We have some amazing speakers today. Claudia, Melvina, Julie, Mark, and Heather will be speaking to us about inclusive digital sexual health services and research. So without further ado, I just want to start by saying, I will ask them each to introduce themselves, but I want to first acknowledge the land on which I am at the moment. I'm at the University of Toronto, and I just want to acknowledge that for thousands of years, this has been the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit, and also under Treaty 13 with the Mississaugas of the Credit. I want to also acknowledge that this place of Toronto, or Toronto, is home to many Indigenous people from across Turtle Island, North America, and we are grateful to have the opportunity to do our work on this land. So I just want to take a moment to acknowledge our space and our presence and be my gratitude to be a visitor upon this land today. I'm going to ask each of our speakers to just very briefly introduce themselves. Then we're going to have each program talk a little bit about what their work is in both Sequence Digital and the eSexual Health Clinic, as well as Get Checked Online and the Digital Sexual Health Initiative. Then we're going to ask for some specific examples around inclusiveness, and we will be allowing opportunities for some questions from the crowd. We're going to ask people to use the chat function for questions. We hope we'll be able to get to as many of them as we can. If we miss you, we will see what we can do in terms of trying to address those questions. I'm going to try to moderate them as best as I can, depending on how busy we are. So I'm going to ask each of our speakers to just briefly introduce yourself, your name, anything else you want to say about your title or your role, your pronouns, and what your position and role is in either the Digital Sexual Health Initiative or Sequence Digital, and very briefly, why you're interested in digital sexual health. So why don't we just start with Claudia?
Hello, everyone. Fabulous to meet you all and to be here. This came out of an academic friendship and a desire to get two research groups together. You are all so welcome to join us. If you like it, we'll do more. We'll carry on talking as research groups, even if you don't like it, but you are all more than welcome, and we're delighted to have you. I'm Professor of Sexual Health and HIV here in the UK, and I'm a clinician working in the same field, and I'm the Principal Investigator of Sequence Digital. My interest in digital sexual health is that it's undoubtedly a crucial tool in providing effective sexual health services, but I fear we may leave some people behind, so it is worthy of great interest and academic and clinical endeavour.
So we couldn't hear you, David.
Thank you, Claudia. Melvina?
Hello and good evening to those in the UK, where I am at the moment in London, and good morning or good afternoon to anyone else who's joining from around the world. My name is Melvina Woodawusu. My pronouns are she, her. I am a senior research fellow at University College London, and my role on the Sequence Digital program is as program manager. And I'm also leading on inclusion and patient and public involvement and engagement. My background is in medical anthropology and behavioural epidemiology, and I'm really interested in the implementation of digital sexual health interventions and doing as much as we can to reduce any health inequalities and certainly avoid widening any gap.
Thanks, Melvina. Next, Julie.
Hi, my name is Julie McLeod. My pronouns are she, her. I'm based in Glasgow, Scotland, at Glasgow Caledonian University. I have a background in health psychology and behaviour change, and I'm part of the Sequence Digital programme. My previous role, which is actually just kind of coming to a close, is as a research associate, understanding the barriers and facilitators that people have when accessing and using online sexual healthcare, and seeking to overcome those barriers and enhance the facilitators. I have just started as a PhD student, also as part of the Sequence Digital programme. I'm now going to be investigating how to optimise online sexual healthcare for LGBTQ+ youth. And my interest in sexual health really comes around sort of inequalities in accessing sexual health care and sexual health outcomes, particularly for LGBTQ+ individuals, but for everyone in general.
Thanks, Julie. Looking forward to hearing more from all of you. Mark.
Hi, everyone, and really excited to be here today for this important discussion. I'm a public health physician who's based at the BC Centre for Disease Control. I'm also an associate professor at the School of Population Public Health in British Columbia, and I have an applied public health chair on SPBI testing. I use he, him pronouns. I've been sort of involved in some of the work around digital sexual health from the days when we all thought this was the panacea for everything, and was going to have unprecedented reach into populations and remove all the barriers. And I think over time, with my work involved, work with Heather and others around program implementation, really came to appreciate some of the very important nuances around reach and equity and who we're reaching and so on. So that's one of the reasons why I'm really excited to be doing research in this area.
Awesome. Welcome, Mark. And last but not least, for sure, Heather.
Thanks, David. I
think we have a Heather freeze. Yes. Okay. I think we might come back to Heather. Heather might introduce herself at a different time. Heather, are you there? Okay. So in the interest of time, I think we'll move on. Sorry about that, Heather, but we will make sure you get an opportunity to get introduced. So what we're actually going to do first is ask each of the speakers to describe their programs, their research programs. And I think we'll start with the Sequence Digital and E-Sexual Health Clinic. So I'm going to pass that over to, I think, Claudia. Is that correct? All right, great.
Yep.
Thanks, Claudia.
That's great. Thank you so much. I will start by telling you a little about our program, and then I'll be handing over to Melvina, who will go into the detail a little bit more about our approach to inclusion. We have just completed 2 years of a 5-year program of research funding, which is really aiming to provide improve sexual health care for people with STIs within a digital national health service. And I think this is really a nod to what Mark said during his introduction. We're not saying that digital is the panacea for all healthcare delivery. We're saying it has a place, an important place within a wider landscape or a health economy. And in previous work, we developed and put into exploratory studies an e-sexual health clinic, where a person who'd been diagnosed with chlamydia through postal self-sampling or in clinic but not given treatment was able to do an online clinical consultation on their phone. And if their responses indicated it was safe, they could have a prescription for an appropriate antibiotic for chlamydia, which they could collect from a community pharmacy. In addition, we had a loop that enabled those people to assist their sex partners in getting tested and treated. And having shown preliminary evidence of effectiveness, safety, and favourable costs in exploratory work, we successfully won the money for a whole new 5-year programme of research. Next slide, please. The programme itself is split into 5 work packages, and these are not sequential. Many of these are overlapping. The work that we'll touch on today really looks at work package 5, research into practice, inclusion, and how we look at generating products from research that can go straight into clinical care without the usual gap at the end of a research project where the researchers look at the clinicians and we go, well, we've run out of money, we've spent hours, and the clinicians say, well, we've not got any money to do that nice piece of work that translates your research product into clinical care. The work that is the centre of this is a trial of the e-sexual health clinic, where we will look at safety, effectiveness, costs, and inclusion. And inclusion is absolutely critical at all stages. We want to design for maximum inclusion and reach. We want to understand the barriers that people with different accessibility issues might experience, and really challenge ourselves to design for maximum inclusion. And where we can't include everybody for safety reasons, we measure that and we look at alternative provision through that. You can see the work streams outlined here. We haven't started the trial yet. We are working on work packages 1 and 2, optimizing everything ahead of the trial. And importantly, work package 4, beginning to evaluate the equity as we will evaluate the efficiency throughout the trial. Next slide. And just to show you, we are a varied group of clinical academics, lay people, social scientists, health psychologists, epidemiologists, public health planners, statisticians, and trialists. And I will hand over now to Malvina for more specific detail on our approach to inclusion.
Thanks, Claudia. I think the first thing to say about our approach to inclusion is that we really want to think of this very broadly and not just in the sense of our research participants or lay members or community contributors that work with us, but also at the governance level and the structural level of our programme. And very much our approach is really focusing on cultural competence of our team, accessibility of our team, and how that filters down towards a more representative and diverse sample of participants and people involved in our research. And the rationale behind that is trying to make sure that our research is as relevant and acceptable to our, I suppose, target populations or the people that we're trying to support and help and work with, as well as developing effective, truly effective and impactful interventions that meet the needs of a wide group of people. What's also really important for us is establishing and maintaining working relationships with community members and their representatives, because we really do realise from previous experience that it's the softer work that can be the more challenging work, and hopefully we can talk about that today. So our team embarked on producing an inclusion strategy and a focus on patient and public involvement and engagement within that. And we really wanted to set an expectation amongst our research team and provide a structure for being able to take an inclusive approach from the start. Part of this is looking at standards that exist within our NHS and health funding landscape, which support us, but also setting our own standards amongst our research team and finding ways to document, measure, and evaluate how we involve a broad spectrum of people for maximum impact. Our approach then, just briefly, it allows us to use various different inclusion, I suppose, techniques So we would look at involving people through consultation and advisory roles, but also through collaboration and co-production. And we're doing this throughout the research cycle, and that started with lay representation on our governance level, in our essentially like a board of governors, a program steering committee, as well as our co-investigator group, which are more operational and strategic researchers. So that's how we're kind of embedding inclusion throughout. And what we're trying to do is establish ongoing opportunities for public contribution throughout the study, and to have a diverse group of people help us decide when that input should be, rather than us as researchers saying, this is when we want to bring you in. We're trying to be much more inclusive in our entire approach. We do also hope to be somewhat of an inspiration in the way that we're working, because although patient and public involvement engagement is very much expected now within our landscape of health research, sometimes it can be challenging and the structures are not always in place to actually support that. So this is something that we're working on and trying to make a point of reporting on our experiences and engaging in hopefully more conversations like this to share learning and advance the, I suppose, participation science alongside the work that we're doing. And hopefully through our discussions today, we'll be able to talk about how we have, actionably involved community members and engaged in co-production and so on. I think that the how is often a question that we're asked in terms of inclusion, and how we approach it and what you actually do on an operational level. And we might come back to this table later, but just to give you a quick orientation to it, I think some of the pre-trial work that we've engaged in so far that Claudia mentioned has given us a really good opportunity to involve lay and public contributors very early on within our research cycle, before we began recruitment or even finalizing our research materials. And so we have on the left a number of studies. These are pre-trial studies that looked at current experiences of online sexual health care, including partner notification and the requirements of different groups for online sexual health care moving forward, alongside a very user-focused website. And at all of these stages, we use different communication methods to engage different individuals in different activities. And so I've listed some of those there, which includes reviewing our study protocol, looking at topic guides, working with us to refine personas and visuals that are used in our pre-trial data collection. There are lots of different ways that we've tried to involve a wide group of people, and a lot of that has been aided by our relationships with community-based organisations, and we'll be able to give an example of that a little bit later. To touch briefly then on the impact of this process and this inclusive approach from the start, I would be really pleased to share that we won an award at a recent BASH conference. So this is the British Association for Sexual Health and HIV. And we submitted an abstract detailing our co-production approach to our PPIE strategy, so our patient and public involvement and engagement strategy, and how that informed our recruitment plans for our pre-trial studies. And within the contributions, we had a diverse range of ages, ethnicities, genders, and so on. And we established really nice working relationships with community-based organisations. So I won't read through everything on this slide because I'm really looking forward to engaging in discussion later, but hopefully that gives you an overview of our approach to inclusive research to inform this research that we're doing.
Great, thank you, Malvina. Really appreciate that. That's helpful to know more about the work that you're doing, and you will have an opportunity to think through a little bit in a little while. But we're going to now step over to the Digital Sexual Health Initiative and Get Checked Online to describe their program, and I'm going to ask Mark to take the spotlight.
Thanks, David. And great to hear about the processes that are really being embedded in the UK model, which are great to hear, and started tweaking some ideas for me. So as mentioned, Heather and I are sort of going to be tag teaming the pieces from BC, and I think just it also speaks, I think, to a really fundamental element of kind of how we do our work here. That you know, I'm speaking to the research side of the house through the Digital Sexual Health Initiative, but we are really embedded with the work of implementation and program development, and that's through the BC Online Sexual Health Services, which Heather will be able to speak to. All right, let me. There we go. So just to note that DISHI is a national collaborative, and we do have some international academic partnerships as well. But the research is primarily focused in Toronto, in Ontario, and in BC from all the province, but our team is in Vancouver. I just want to acknowledge, I know that my Toronto and Ontario colleagues are doing fantastic work as well, or have done fantastic work around inclusion and diversity and community engagement, but today I'll be focusing on the BC side of things. And then just to put things in perspective, I mean, I found this on the internet, so it must be true. The British Columbia is a very large geography, and our program has a provincial mandate. So we're sort of thinking about testing across the province. We also have a population of 5 million people. So it's a fraction of the population comparatively of United Kingdom and Ireland. And much of our population lives along the southern border, southern part of the province, but we have huge numbers, massive numbers of communities that are rural and remote and Indigenous, and that's really a part where testing barriers are greatest and where we're now starting to think a bit more deliberately around sort of that geographic inclusion and diversity. Just to acknowledge that our work of the team is based in Vancouver, which is on the traditional unceded territories of the Musqueam, Squamish, and Tsleil-Waututh nations. And much of the work I'll be talking about today in our work of DISHI has been related to Get Checked Online, which is BC's internet-based testing service for STIs, STBIs. So just to tell you very quickly about how Get Checked Online works, it's really developed and sort of seen as a solution for overcoming barriers to accessing testing. You visit the website, create an account where you provide some basic demographics. You're then asked to complete a series of risk assessment questions for recommending tests and for ultimately getting a lab form, which you can print or just have on your phone. When you go to the participating lab, we partner with a private company, Life Labs, for specimen collection, and that includes blood for HIV, syphilis, and hepatitis C, urines for chlamydia gonorrhea, and then rectal or throat swabs, depending on whether it's indicated for chlamydia gonorrhea testing. All the results are managed through a provincial STI clinic at the BC Centre for Disease Control. If negative, all results can be accessed online. If positive or indeterminate, one of the clinic nurses contacts the user to arrange for follow-up. And an important step also is repeat testing, because we have a very large proportion of people who use the service repeatedly. And that's becoming a bigger part of the users over time. Currently, right now, it's available in 8 communities across BC, as I mentioned, sort of across the southern part of the province, with some dense urban areas like Vancouver or Victoria, but then also some more suburban and rural areas as well. From our research, we know that Get Checked Online does reduce barriers. The figure on the right is sort of a comparison of people's reported histories of challenges accessing testing between Get Checked Online clients and clients of our provincial STI clinic. And you can see across the board for issues related to interactions with providers or physically being able to access clinics. These are barriers in the past more commonly reported by Get Checked Online clients. We also know from interviews that it's really valued because of convenience, anonymity, and control over testing. But we know the question is still, are we reducing barriers for everyone? And I think that's sort of getting at this piece of being attentive to where we may have gaps and for the work that's needed. So one of the things that we found, for example, has been in some of our survey work with gay, bisexual, and men who have sex with men, we see this contrast between who is aware of the service and who uses the service. So we see, for example, men who are more connected to the gay community or out to their healthcare provider are more likely to be aware of this service, but they're also less likely to use it. And the folks who are then, potentially who would more benefit from it are less aware and are not using it. So I think this really speaks to some of the practice implementation and where research can really help to sort of flesh out some of these things. We've also, in addition to sort of geographic diversity, we've sort of got priorities around thinking about non-English speaking populations, ideally thinking about folks with lower socioeconomic status. And these are groups where we have not yet sort of deliberately engaged around researching. These are priorities for us going forward. In terms of how we sort of think about sort of our community engagement, and I appreciated this webinar because it was a chance to really kind of think a little bit more concretely about this. As I mentioned, this is really how we conceive our team's approach. So as I mentioned, there's the research side of things. We have the program side of implementing and designing the ongoing work of adaptation and maintenance and scaling up, which is a huge task around in interventions. And then community as sort of, it's a bit of a monolithic statement, but that's kind of like as a third and equal partner in our work. And some of the ways that we really try to sort of respect this sort of community as a really important partner is a couple of ways. So we have a sexual health advisory group called SHAG, which is really supporting the programmatic side of the design and implementation. We have a community advisory board for our JISHI initiative with the CAB chairs who are part of our executive team. Throughout the process of developing Get Checked Online, we've established relationships with community organizations who've been really key at providing input and making sure that the design is important, as well as engaging around some research activities. More recently, we've started trying to really hire peer researchers into our research studies. I know that some of the Toronto team's done a great job of, and this is something we're focusing on in BC also. So for example, last summer we engaged peer researchers from the different communities where Get Checked Online was available to be part of a community survey. We do population-focused studies, so we're planning to embark on a study looking at non-English speaking populations, and then but also user-centered design being a really key component of really making sure that we center sort of patient and user experiences and that sort of like broader community lens. But also just saying that partnerships are key, and these are just some of the partners that we work with, ranging, and it's including academic as well as laboratory, clinical, and community partners. And it's really been through the strengths of these relationships that we've been able to do our work successfully. And I will stop there.
Great, thank you, Mark. I just want to check for a process. Does it make sense for Heather to speak now or speak to the follow-up section? Just checking in. Heather?
I can quickly introduce myself, but I think I'm mostly speaking to the follow-up section.
Okay,
so
great.
And sorry about that. I have intermittent issues with my bandwidth here apparently. So I am the online sexual health manager at the BC CDC. So I manage Get Checked Online, and but my work really is around or like I guess the passion of my work is around kind of improving access to testing and sexual health services generally in BC, and so and also ways to kind of incorporate community perspectives and community voices into our clinical services. So I'm one of the co-facilitators for SHAG, our community advisory board that Mark mentioned there. As well as collaborating on various projects, for example, around self-collection. So that's me. And so again, sorry, I'm handing it back over.
No, we're just thrilled that you're able to introduce yourself. I'm glad you're here. Totally glad you're here. Okay, so we're just going to move on to the next section now, which is we've asked, obviously, these two amazing and innovative programs and sisterly programs have, are doing some great work and bumping up against some issues around inclusion. And I know some of it has been addressed already, but I want to kind of dive a little deeper in that regard. I do want to remind people that I'm going to ask some questions of the panelists now, but if there are questions that you have, to please feel free to put them in the chat. I'm going to do my best to moderate any questions that come up in the chat for our panelists to speak to. So I think, because we have a sense now of kind of the broader context of providing these services, we're also kind of like wanting to address today even more in depth a little bit about improving inclusiveness. That can be a very broad term, so we're looking for each of you to kind of think about how you've considered that. Both of you have talked a little bit about it, but I think it might be good if we could get some examples of what you've had to walk through, what you've had to deal with in kinds of improving service inclusiveness. So basically what I want to ask each of you, and I think I will start with Claudia and Melvina, if you could talk a little bit about, kind of what was there a particular gap or issue that you tried to address? And then how did you engage those communities? Like, one of the things that seems very obvious is community engagement and participation. So how did you engage with those communities? What was the process? What was the strategy? Maybe any lessons that you've learned from that and how it ultimately kind of has worked out. So I'm not sure if that's going to Claudia or to Melvina.
I think what I will do is give you a bit of a top level, and then I know that Julie McLeod is going to present as a case study a little bit more detail. So thinking about the big heading here, we were very focused on people who might have poorer health literacy, poorer digital literacy, or perhaps poorer literacy, because we felt that these were people who were easy to be missing from online postal self-sampling services and the type of online clinical care that we think we can deliver safely online. So one of the core studies for us as part of trial development was to look and examine barriers and facilitators to engagement with online sexual health services in people who might or have already struggled with online sexual health services in the UK, given that the UK has been using, or certainly England, postal self-sampling services for a good number of years now. So with that as a sort of overarching example, I don't know if now you want to move to Julie to describe the case study, or I might have wrecked the format of the session. So completely over to you, David, who you want when.
No, I have wrecked the format. It is to go to Julie. Thank you for highlighting that. I'm good at wrecking formats. Julie, yeah, we'd love to hear your contribution to this process for the sequence project.
Thank you.
Yeah.
Yeah, so to build on what Claudia was just saying, the research that I was leading on was about the barriers and facilitators to people accessing and using online sexual health care. The focus was on people with lower digital health, digital literacy and health literacy. The aim really was to maximise inclusivity and uptake of the e-sexual health clinic to really sort of reach the most amount of people that we can with the e-sexual health clinic. With regards to how we engaged the communities in the recruitment strategy, so the recruitment was guided by the Progress Plus framework. For those of you who don't know what that is, it's a framework for inequalities, demographics associated with inequalities and health outcomes. So recruitment was guided by this, as well as demographics associated with lower digital literacy and health literacy. And there's massive overlap in those demographics. And these included things like lower socioeconomic status and with regards to employment and occupation, education, things like that. Ethnic minorities and people with learning difficulties, for example. So we started with target demographics for each of the groups, like the populations that we knew we wanted to reach. We knew it was going to be qualitative research, which we had a target sort of sample of 30 to 35 people we wanted to recruit. So we sat down and worked out of these 35 people, we know we want that about 10 of them to be of ethnic minorities with a focus on people who are of Black Caribbean or Black African background. We know that we want 10 of them to have learning difficulties, for example. So we started off with those target demographics, which made it a lot easier to reach the targets as we were going through, and I'll explain a bit more about that in a minute. And we started off before we actually started the data collection and recruitment process, thinking about which community-based organisations we could work with to meet these target demographics. So we had lists for each of them. So we started off very prepared. So the recruitment strategy after this to actually sort of enact the recruitment was a process of referral and identification through National Health Service staff, NHS staff. We worked with a couple of NHS sites across the UK, including Scotland, and as well members of staff from community-based organisations. I have been told that my accent can be difficult to understand, so if anyone has any questions or wants me to repeat anything, please let me know. I'll continue though. But yeah, so we were working with NHS staff and community-based organisation staff, and basically they were referring people to me who met our primary criteria. And the primary criteria to try and reach people of lower digital literacy and health literacy was having never tried to order or having struggled to order and use STI self-sampling kits, which are available to order online. So if people met this criteria, along with a couple of other criteria, such as being aged 16 and over, living in the UK, things like that, they were referred to me. And then I took them through a screening process. And this screening process allowed me to really monitor the sample closely with regards to each of the target demographics we were hoping to meet. So as I was going through and interviewing people, I was keeping a really good record of the demographics of the interviewees. So that allowed me to feed back to each of the staff members that were referring people, and this really helped with the recruitment process because I could identify we're not reaching these demographics, or and that really helped with making sure that we were getting diversity in the sample. And as well, the community-based organisations were fantastic because they were focused on specific populations. So I ended up working with 3 community-based organisations. These included an organisation that worked with LGBTQ+ Muslims, people with learning difficulties and living with disabilities, and lecturers at a college in Scotland who are working on a course that is specifically targeted for people who have been out of education for 5 or more years, who left education from high school without any higher qualifications and are living in deprived areas. So they already screen people for getting onto the course. And I knew of this course, so I got in contact with them and they helped with the referral and identification process. And that was fantastic for meeting some of our target demographics. And I also worked with a specific NHS site, one clinic that works with vulnerable women, so women who are experiencing homelessness and addiction. So there were a lot of really targeted organisations that I was working with for recruitment to try and really reach a diverse sample and to reach people that we really wanted to talk to. One of the challenges that we faced with the NHS organisations was that the clinics, the clinic leads and the people sort of referring people from clinic didn't always ask some of the questions. They weren't ascertaining some of the information that we would need. Like they weren't asking people if they have a learning difficulty and things like that. So they weren't always able to target certain groups. And that's where the community-based organisations could really help with that. But one of the challenges we had with the community-based organisations was we were doing recruitment in 2020 and 2021, so COVID. And this was a really big issue because there were a number of community-based organisations we wanted to work with, and they just didn't have capacity to work with us at that point in time, which was such a struggle. So the outcome of this really was very successful, and we reached the majority of the target populations that we wanted to, but there were a couple that we didn't reach, one of them being people of Black African and Black Caribbean ethnicities. Because of the community-based organisations we tried to work with, they just were at capacity and they couldn't help us. But we did manage to reach the rest of our target demographics. So for example, over 51% of the sample were living in the most deprived areas in the UK. Over a quarter were of an ethnic minority. Over a quarter had English, English was not their first language. Over a third were unemployed. Over a half had no higher education. Over a half self-identified as bisexual, pansexual, queer, or gay. Over a third self-identified as having a learning difficulty, and over half identified themselves as living with a physical or mental disability. So we were really proud of the diversity we got in demographics. And when it came to the sort of lower digital literacy and health literacy side of things as well, 2/3 of the sample had never ordered or tried and struggled to order a postal STI self-sampling kit. And 20% had ordered one of the kits, but then struggled to use it as well. So yeah, but we did really well with the sample. Despite not meeting all of our targets, we met the majority of them and we're really proud of it. Over half as well had reported their skills using the internet as low to medium, and over 1/3 had never searched for any sexual health information before, and not a single one of the participants had ever used a live chat or an email service for sexual health support and advice online. So it was an incredible experience to get to interview these people. That's my spiel. So
Thank you, Julie. No, that's fantastic. I mean, you actually covered a lot there. I really, really appreciate it, because I want to make some comments, but I actually think instead I'm going to turn to because I have some thoughts about if there are some similarities. So I do want to turn to our folks here in Canada to have an opportunity to speak about their experiences. Similar question, what was a gap or an issue that you were trying to address? How did you engage communities that were affected? What was that process? What was your strategy? What were the challenges? What were the lessons learned? And then what was the outcome? So I believe I'm passing that to Heather. Is that correct? I did it right this time. All right.
Sure. Yeah. And I'll try to answer most of those questions in my spiel, but feel free to prompt me if I've missed anything there.
Absolutely.
So the case study that I'm going to be talking about is around changes that we made to how we collect and use gendered information through Get Checked Online. But I mean, in terms of what kind of triggers priorities around changes that we make to Get Checked Online and how that works, it's kind of informed by a number of different things. One is Mark's research team and just the findings that are coming out of that work while they're kind of continually doing equity-focused research on Get Checked Online, as well as, public health and community priorities that come out from our community and public health partners. But also just direct feedback that we get from clients. Like, I'm the person that monitors our Get Checked Online email box. And so we're constantly getting feedback from folks around changes that they'd like to see or what's working and not working about the service. And the last one is that, we don't really see equity review is something that kind of happens once. That basically, since Get Checked Online was launched in 2014, the first equity review that was done on the operational side was in 2015, the very next year. And so we've had a number, and the next one was in 2017, and then I kind of picked up the work from there when I joined in 2018. And so doing equity review and an evaluation is something that we see as iterative. And that's kind of where it was kind of signaling to us that we were needing to make some changes around, gendered information. And the other piece is, again, for this work, that was really important was like direct partnership with, so we partnered with Transfocus, which is a trans consulting group located here in BC. And so just partnering directly with like the communities that we're going to be working with. So yeah, then I guess in terms of the approach that we used for the changes. So it was, same as the folks in the UK, we kind of used a lot of different approaches. So we kind of see consultation as something that you do often in different ways and with different types of people. And so we kind of started with a literature review, followed by community consultations. So we held interviews with 5 organizations that serve trans and gender diverse communities to ask them about how they collect data and why, and to get their thoughts on Get Checked Online's approach. And like I said, we also had that direct partnership with trans individuals and organizations who kind of worked with us at every step of the process. and also worked with TransCare BC, which is the agency within our health authority that's tasked with trans health. So once we kind of had a proposed direction, we had multiple rounds of internal review and discussion with our clinical leads and teams, and also had to do the mapping across health information systems, because this is a clinical service that's embedded within our public health systems. And consulted with 3 different community advisory boards. So TransCare BC's community advisory board, SHAG, our STI services board, as well as the Get Checked Online research group at different stages of design and review. And then after a few rounds of working and reworking our approach, we held focus groups. There were 4 focus groups based on identity, so trans, cis, gender diverse, and two-spirit, and most had about 8 participants in them. And lastly, we did usability testing on a prototype to test the actual application changes. So yeah, that was, that's one example of, how we've done consultation in the past. And then I think the next question was around what worked and didn't work around the approach.
Yeah, any kind of like lesson learned that you'd want to share, and then briefly, just based on time, what the outcomes were.
Sure. Yeah. So just some lessons. I think I kind of mentioned some of them. So one is around just ongoing evaluation adaptation, and the other one around kind of centering voices. So consulting often and with different types of people. But I think the other one is around really like shifting power in these kinds of situations, which is, I think, a lot harder for us to do, especially within clinical scenarios where there's a lot of things that can't be changed. So for example, in this work, it was about a lot more than just kind of changing what the gender categories are within a system, that it really does come against some of our other lab or information system limitations that are not, or surveillance, like those kind of things that aren't things that we can change on our own. And so what we found was, it's really important to give people to help with that kind of shifting power piece, giving people the whole picture, and transparency of information. I think a lot of the time we can be a little bit gatekeepery in clinical services and say, and only share the information that we think people need to know. And so when you're doing consultation, it can be really important to be really transparent with people about what the limitations are, why things are the way they are, and really helping people through that journey. And I think also just, action and accountability, right? Like although there's things that we can't change on our own, to still not lose sight of that when you kind of make a set of changes, to still be chipping away at some of those bigger system pieces as well. And that, helps with trust and relationship building. Yeah, I think I've rambled enough here. Was there anything
great.
I missed?
Thanks, Heather. No, that's really great. That's really helpful. I think I know our time is a little short. I just want to summarize and then maybe give people on the panel an opportunity. Not everyone has to respond, of course, because that could take a while, but to think through a little bit of a question I have, which is, so what I'm hearing, like the summary of it in my mind is that there's sort of an exponential need for communication and collaboration and taking time and making effort to ensure that there's a good level, a solid level of representation of lived voices, people with lived experiences, sharing power, and also that sometimes the agencies or groups that we might want to share power with or provide voice, be inclusive of voices, sometimes that puts a burden on those communities as well too. And I think Julie mentioned something to that, but Heather, you were alluding to it as well. And I'm just wondering, is there any trick to kind of making sure it's very easy to like write a grant and a proposal, but actually, Heather, one more point I really like that you said was about the ongoing nature of equity and inclusion. It's not just a one-shot deal, right? It's not like, okay, we're going to do this, but there's a constant kind of revision and review. So I'm just wondering, how do we make sure that, the funding we get for studies for this kind of work actually really is inclusive of that inclusivity, if you will? Like their funders have different takes on all this, and how, are there any tricks to making sure if I'm going to do this, I want to make sure that people who provide these resources are not going to make me add burden to my community organizations or people with lived experience? Melvina, I see your hand is up. I don't know if it's regarding that or something else, but go right ahead.
It's a real hand, thank you. I just wanted to pick up on that point around finance. So with my kind of program management hat on, I think this is a really important and possibly overlooked area. I think sometimes when we're costing our work and thinking about inclusion, the obvious thing to do, or the first thing to do, is to think about remuneration for people that are working with you, so community members. But I think we also have to think about whether or not it's possible to support financially the community-based organisations that we work with. And we were able to do that with the work with the organisation that deals with people with mild learning difficulties and disabilities. We were able to provide some financial support so that it would cover the cost of the person that was helping us and working with us. So I think it's really important to consider that. I think training is also an important thing maybe to factor in, is that really we're talking about cultural competence here, and I mentioned it earlier. I don't think we can make the assumption that somebody in their research role who takes on this task or this activity is best equipped or well equipped yet to be able to work with these groups. And I think it's important to factor that in as well. I do want to pick up on the point that Heather made around accountability and transparency. I think this is so important and speaks to our the power dynamic shift that we're seeing really when we talk about participation science, is that we need to be really mindful of the fact that as researchers, we may be more used to having the power and we currently have the information. But when we think about knowledge transfer, this has to be a two-way street. And we have to be mindful that the reason we're going to or approaching community-based organizations is because we actually need them. They have the trust of their communities, they have the local knowledge, they have the kind of grassroots understanding of what's going on. And we really can't actually do a lot of our work without them. And I think the recognition of that is really very important and should come alongside the transparency, that genuine co-working, as well as accountability. So we recently conducted I suppose a scoping workshop to understand how we can have a cross-study approach to community and a community advisory panel that we want to set up. And what we're really, the aim of that and what we're conscious of there is that when different UCL or University College London studies approach perhaps the same community-based organisations, it's not clear that these are separate studies or perhaps separate aims, and being able to have a unified voice and has allowed us to share resources and provide accountability throughout the year. So often with our studies, we might want to engage perhaps to support recruitment. And that's quite a short-lived, discrete piece of work. And then from a community-based organisation, they just don't really hear from us again. If you're doing it badly. If you're doing it well, then they would hear from you all the way. But I think that cross-study approach allows us to maintain communication and therefore build trust over time, rather than just being seen to approach these community-based organisations when we need something from them and not necessarily sharing how their work has really impacted and influenced what we're doing. So just a couple of points there. Accountability, I agree with Heather. Transparency, I agree with Heather. And the point around finance and costing and grants, I think is also one just to make again.
Yeah, no, thank you, Melvina. I think you said some really awesome points that I think are very critical to these conversations. And you're right, if different people are constantly going to the same group and there's no coordination and lack of communication, I think you just painted a fairly coherent way of kind of thinking through some of these various issues that have been raised today. That's fantastic. Thank you. I know we just have like 2 minutes, so I don't know if there's anyone else in the panel who wants to try to answer one of those questions. Claudia.
Just thank you for that opportunity. I think there are no shortcuts. There are ways of doing this efficiently, and there are ways of doing this to help the community-based organisations. But I think there are no shortcuts. And I think, as you saw with Julie's work, we tried really hard. And we actually, for another grant application, I would factor in more time needed to conduct that research, because if you're going to do it properly, you have to keep putting the effort in to reach people that we're not very good at reaching. And I think there's always, we can't ever become complacent. We can't go, oh, we've talked to people from that group. I think we have to very much interrogate each other and say, have we really? Have we really talked to the people who might struggle the most in that group? Because I think we're doing people a great disservice and being disingenuous if we talk to the people who are the easiest people for us to find within those groups. So I think it's just putting the ball back in our own court and saying, whether we're developing a service or research, are we really sure that we have reached a rounded selection of voices, even within a very small sub-community, that reflect the types of difficulties or facilitators that particular people might experience? So it's really hard work, but hopefully we just keep trying, and that will improve our services in the way that everybody would benefit.
Yeah, that's fantastic. Fantastic. Thank you, Claudia. I was just thinking as you speak, like we also have, besides recognizing the power that we carry and what we have to do and manage and think about as we engage with communities, but also trying to think through a little bit about the ways in which we even begin to frame our work, or allowing ourselves to make mistakes and to learn from our mistakes without it becoming a defensive closing off, but like, how do we ensure that we're really kind of reaching to the larger communities? So I'm recognizing our time is up here. I want to say thank you so much to all of our speakers, to Mark, to Melvina, to Julie, to Claudia, and to Heather. Thank you so much for your time and your expertise. And I really appreciate the opportunity to chair today. And I'm looking forward to seeing the ongoing good works of all of you. So thank you.
Thank you, David.
Thank you.
Brilliant job.
Absolutely welcome.
Thank you,
My
David.
honor and
Thank
pleasure.
you.
Yeah.
Okay. Bye.
Okay. Thanks, folks.